This module is part of the Canadian Injury Prevention curriculum. Audio is required for an enhanced learning experience. Throughout the module, you can access the glossary by clicking the upper left-hand corner in the toolbar above the video and the resources below the video. If at any time you are confused, stuck, or need help, you can click on the upper right-hand corner in the toolbar above the video. Welcome to Data Methods and Interpretation for Injury Practitioners. This module will introduce you to basic knowledge about different injury databases, resources, where to find them, framing a research question, and how to interpret injury data. The glossary found here contains terms and definitions that will be used throughout the module. If at any time during the module you would like to review a term's definition, this glossary can be accessed on the upper left tab in the toolbar. Upon completion of this module, you will be able to understand concepts such as incidence, prevalence, and burden of injury, identify injury databases, and interpret injury data for your own research uses. Before we begin talking about different databases and the types of information that we can extract from these databases, let's review the public health approach and the role of surveillance. Surveillance is captured under the defining the problem component of the public health approach. Throughout this module, we will learn how different databases can help us define the problem through surveillance. We begin by defining the injury problem and systematically gathering the data we are interested in analyzing. In order to establish the burden that Canadians face due to injuries, surveillance measures include both morbidity and mortality data. By using morbidity and mortality data, closer attention can be paid to both the prevalence and severity of certain injury types. Injury indicators such as mortality rate, potential years of life lost, and hospital separation rate have also been used to define the burden of injury in Canada. These outcome indicators are often used in research by calculating incidence rates, prevalence rates, and the burden of injury. Let's start by looking at the most common method of reporting injury data, incidence rates. Incidence is defined as the number of new cases of a given condition occurring within a defined population. For example, in Ontario, from 2002 to 2003, the rate of ED visits for young children aged 0 to 4 was 12,410 per 100,000. Incidence rates are commonly used as a measure of morbidity, for example, healthcare utilization, and mortality, calculating the number of deaths. Prevalence rates are less commonly used in injury reports and are generally used to define infectious or chronic diseases. Prevalence is defined as the number of cases of a given condition at a specific point in time. The difference between incidence and prevalence is that incidence refers to new cases of a specific condition, whereas prevalence refers to existing cases. The burden of injury is becoming the most effective way of defining an injury problem. Burden is calculated by looking at how much it costs the healthcare system to care for injured individuals during the time of their injury. This includes information such as time lost from work, damages to person and property, and any long-term disability costs. Later on in this module, we will discuss injury reports that have measured the burden of injury and how we can interpret these types of reports. One common measure of burden is potential years of life lost, or PYLL. PYLL looks at the burden suffered by individuals who died at a young age. It is calculated by using average life expectancy and subtracting the age at which the person died from a specific injury. Consider the following discussion. It seems like every day we have people coming in who have been in a severe car collision.
Yeah, that's true. It's so sad. I wonder how many of those people end up dying from the collision. I wonder if there's a place where we could find this information.
Now that we know a little bit about some of the methods that we can use to calculate injury hospitalization and death rates, let's briefly talk about framing a research question. Why is it important to frame a research question? The research question is one part of surveillance. Like the nurses in the scenario above, if we were interested in knowing how many people end up dying from motor vehicle collisions over time, we could look at these trends by framing a research question and using the appropriate database. These trends could outline the incidence of motor vehicle-related deaths over time. When framing a research question, the following 4 elements are commonly used in the evidence-informed process. 1. Population. 2. Intervention. 3. Comparison. And 4. Outcome. We will use the example of bicycle helmets and cycling-related head injuries in young children to illustrate PICO. Patient/population/problem. A researcher must first ask themselves who are the population of interest. Young children? Adolescents? Older adults? Males or females? What is the injury problem/issue that the researcher wants to know more about? Using our example, let's say we were interested in cycling-related head injuries among young children aged 5 to 9 years, with and without a bicycle helmet, who were admitted to a hospital for an injury between 2010 and 2012. Our population would include a defined age group and sex, boys and girls aged 5 to 9, a specific injury problem, cycling-related head injuries, a specific exposure variable, helmets, and a specific location/population, hospitalized between a certain time frame. Intervention/exposure. Next, the researcher must ask themselves what intervention or exposure they are interested in. For example, if they wanted to know about the protective effects of bicycle helmets, then we would find a database that could tell us whether or not the population was wearing a bicycle helmet at the time of their incident. Comparison. What is the alternative to the intervention or exposure? Continuing on with our example, if our intervention/exposure is wearing a helmet while cycling, then the alternative group we would be interested in looking at would be children who did not wear a bicycle helmet at the time of their injury. Finally, outcome. What is being measured? In our example, we are measuring the rate of cycling-related head injuries. Once you have framed a research question, you should determine the variables that you are interested in analyzing or interpreting. When researchers are interested in analyzing a particular variable, they can often classify or stratify this variable into a specific category. Some common ways of stratifying data are by intent, cause, place of occurrence, nature of injury, and severity. Injuries are classified as unintentional or intentional injuries. It should be noted that sometimes a distinction is made, but it is unclear whether the injury is intentional or unintentional. For example, in boxing, the opponents are intentionally inflicting injury onto each other. However, because the rules of the game are respected, these are classified as unintentional injuries. Some examples of unintentional injuries include MVCs, falls, and burns that occurred inadvertently or by accident, whereas intentional injuries include injuries that are the result of violence or are self-inflicted. Another common way to classify/analyze injury data is by the external cause. This refers to the event that occurred that caused that individual to sustain an injury. These external causes can be unintentional or intentional. Some common examples of causes include motor vehicle collisions, falls, poisonings, fire/burns, drowning, and stabbing/piercing wounds. Using our cycling-related head injuries example, some possible causes of injury could include falling off your bicycle and sustaining a head injury, or getting into a collision with a motor vehicle while riding your bicycle and sustaining a head injury. Some injury data researchers are also interested in looking at where the injury takes place. For example, Are the children who are sustaining head injuries while cycling hurting themselves in their neighborhood, riding to school, etc.? Nature of injury is an important outcome variable that many injury researchers study. The nature of injury tells us what type of injury the individual sustained. Did they fracture their arm, sustain a hit to the head, sprain their ankle in a soccer game, burn themselves, dislocate their shoulder? Nature of injury tells us what happened and what body part or body parts were affected. Injuries are also classified/analyzed by severity. The most severe injuries that result in death are analyzed using mortality data. Other measures of severity include severe trauma, hospitalization, ED visits, injuries treated by a physician, as well as injuries that are left untreated or are self-treated, for example, ice packs. Many databases contain information about the circumstances around injury and the nature of those injuries. You just need to know where to look. So now that we've learned how to frame a research question and some of the ways we can classify/analyze injury data, let's talk about where you can access the data that you need to answer your research question. We will start by describing some international, national, and provincial morbidity and mortality databases. We will dive into the types of data that can be analyzed as well as the strengths/limitations of these data sets. We will conclude this section with a number of reports that are already available on various injury topics and how to interpret some of this data. If a researcher is interested in mortality data, there are two databases at the national level where they can access this information: Vital Statistics Death Database and the Coroner Canadian Medical Examiner Database, which can be accessed through the Statistics Canada website. Vital Statistics: an administrative survey that collects demographic and medical, cause of death, information on an annual basis from all provinces and territories statistics registries on all deaths in Canada. The data are used to calculate basic indicators such as counts and rates on deaths of residents of Canada. Information from this database is also used in the calculation of statistics, such as cause-specific death rates and life expectancy. Advantages: 100% response rate. The disadvantage to using this database is that only certain variables can be accessed publicly. If you are interested in count/rates of more detailed variables, you would have to speak to someone in the Data Liberation Initiative, DLI, or the Research Data Centers, RDC, program affiliated with your institution for more information. Coroners'/medical examiners' reports. Each province is responsible to investigate the deaths of the individuals who reside in those provinces. Data that is obtained from these reports includes the cause of death, defined as the disease or injury that initiates the chain of events ending in death, and the manner of death, defined as the means by which the death occurred, for example, natural, accident, suicide, homicide, or undetermined. Advantage: only centralized source of standardized coroner/medical examiner data in Canada. Disadvantage: data may differ in interpretation between jurisdictions. A number of detailed analyses on the leading causes of death in Canada have already been conducted. If an injury practitioner was interested in knowing what the age-standardized mortality rate per 100,000 population in Canada for both intentional and unintentional injuries, they could interpret this information from graphs and charts found on the Vital Statistics Death Database. By looking at this graph, for instance, we can interpret that unintentional injuries were the fourth leading cause of death for Canadians of all ages in 2000 and 2012, but we can't necessarily tell what the rate was per 100,000 population. On this slide, however, we have more detailed information that we can interpret as a rate, which tells us that in 2000, The death rate from unintentional injuries per 100,000 population in Canada was 25.8, and by 2012, this rate was relatively unchanged at 25.3 deaths per 100,000. By using these charts and graphs, we do not have to analyze the variables ourselves, but can get a general idea of the trend of unintentional injury death in Canada over a 12-year period. There are a number of different data sources where you can access information on injury hospitalizations, including the Discharge Abstract Database, or DAD, National Ambulatory Care Reporting System, or NACRS, and the Canadian Hospitals Injury Reporting and Prevention Program, CHIRPP. The DAD is a database from the Canadian Institutes of Health Information, CIHI, that captures administrative, clinical, and demographic data on hospital discharges, including deaths, sign-outs, and transfers. All acute care facilities other than Quebec are required to report this information. Basic information that is collected includes age, sex, geography, date, cause and nature of injury, treatment, discharge status, advantages, population-based dataset, disadvantages, no specific detail of the injury/incident because the hospital staff only code what is in the chart once they receive it. The National Ambulatory Care Reporting System, NACRS, contains data for all hospital-based and community-based ambulatory care, including day surgery, outpatient, and community-based clinics, and ED data. However, one major disadvantage to this database is that the information collected varies by facility and province. In addition, the data is not made publicly available, but injury practitioners and researchers can apply to access data from the CIHI or to see reports that have already been generated. Data collection varies by facility, but basic information such as age, sex, geography, date, cause and nature of injury, treatment, and discharge status are provided in this database. Other emergency department databases include the Canadian Hospitals Injury Reporting and Prevention Program, or CHIRPP. CHIRPP is a surveillance system developed by the Public Health Agency of Canada, or PHAC. CHIRPP facilities collect and analyze data on injuries to people who are seen in the EDs of 11 pediatric and 6 general hospitals across Canada. CHIRPP is unique because it collects pre-event data by asking questions such as, what was the injured person doing when the injury happened? What went wrong? Where did the injury occur? Patients complete a one-page questionnaire that contains information on circumstances surrounding the injury. What was the injured person doing at the time? What caused the injury? Factors that contributed to the injury. Time and place of occurrence. Age and sex. Hospital staff fill out nature of injury, body parts injured, treatment. Advantages. Collects detailed and rich information surrounding the injury. Disadvantages. Not population-based. The databases that you have been introduced to thus far are the most commonly used to capture injury, hospitalization, and death data. However, there are a few other databases that are available through Statistics Canada that provide more detailed health utilization information, including the Canadian Community Health Survey, CCHS, and the National Longitudinal Survey of Children and Youth, NLSCY. The Canadian Community Health Survey is a cross-sectional survey that collects data related to health status, healthcare utilization, and health determinants for Canadians aged 12 and over. Data is further subdivided by subject, including diseases and health conditions, health, lifestyle and social conditions, and prevention and detection of disease. The advantages to using data from the CCHS is that there is a large sample of respondents. However, because the data is self-report, there is always a risk of recall bias. Similarly, the National Longitudinal Survey of Children and Youth, NLSCY, is a long-term study of Canadian children that follows their development and well-being from birth to early adulthood. The survey covers topics such as child development and behavior, education, and health and well-being. One major advantage to this database is that it follows respondents over time. However, once again, the data is self-reported through questionnaires. Before we introduce you to some of the international injury reports that are available, there are also some provincial initiatives that give injury practitioners access to injury hospitalization and death data on a provincial level, such as the Injury Data Online Tool, IDOT. From the British Columbia Injury Research and Prevention Unit, BC IRPU. The IDOT is an easy-to-use online injury platform that allows injury researchers, professionals, and the public to access provincial injury data, including mortality, morbidity, motor vehicle collisions, and sports. Data is retrieved from a number of sources including BC Vital Statistics, the Ministry of Health Discharge Abstract Database, the Insurance Corporation of BC, and the CHIRPP. By the end of this module, you will use the IDOT to answer a research question of your choosing. Finally, we will show you some injury reports that have been produced by international groups, such as the World Health Organization, WHO. The World Health Organization, WHO, produces world reports on child injury prevention. These reports present the current knowledge about the 5 most important causes of unintentional injury, including road traffic injuries, drowning, burns, falls, and poisonings, as well as intentional injuries from violence and self-harm. There are general reports that compare injury rates among countries for a number of specific causes. There are also sections where you can access data to tables, figures, and graphs that are easy to interpret. For example, if you wanted to know the proportion of fatal road traffic deaths among children and youth by type of road user, you could find this information on a WHO report, stratified by OECD country. For example, if we wanted to interpret this chart from a WHO report, we would be able to say that unintentional injuries accounted for the majority, 72%, of injury-related deaths in 2012. Of these, road traffic injuries were the leading cause of death worldwide. It should be noted that reports such as those from the WHO use the International Statistical Classification of Diseases and Related Health Problems 10th Revision ICD-10 codes to classify injury hospitalizations and deaths. The ICD-10-CA is a standard coding system that includes over 10,000 diagnostic codes developed by the WHO. These codes capture the nature of injury as well as the external cause of injury and requires detailed documentation. For example, V86.50, driver of snowmobile injured in non-traffic land accident. Translation: snowmobile driver ran into a fence. To summarize, here is a list of some of the databases that provide injury morbidity, mortality, and burden information for injury researchers and practitioners. At the end of this module, there will be a comprehensive list of related resources/links that you can access should you choose to want to review this information at a later date. Some of the information on the incidence/prevalence of injury may already be summarized in a report that we can use/interpret for our own research uses. The first step in interpreting this data is to search for credible high-level syntheses of this information. Local, provincial, and national agencies such as the Public Health Agency of Canada and Public Health Ontario house many of the reports that injury researchers are interested in. For more detailed information, such as information on a motor vehicle crash or on specific injury prevention behaviors like seatbelt use, you can access reports from places such as Transport Canada. Finally, information on the burden of injury can be found by looking at the Cost of Injury report on Parachute's website. In 2015, Parachute published an updated Cost of Injury report. The last one was published in 2009. The report examines all injuries at the national level and provides provincial breakdowns. For example, the report shows that in 2010, preventable injuries resulted in 15,000 deaths, 231,000 hospitalizations, 3,500,000 ED visits, and more than 60,000 Canadians with some form of permanent disability. The Cost of Injury report also provides data on intentional injuries in Canada. For example, in 2011, 3,726 Canadians died as a result of suicide. 521 died as a result of homicide, and 80% of all homicide and suicide deaths occurred among Canadians aged 20 to 64 years. The Cost of Injury report analyzes the burden of injuries by calculating human costs, for example, the loss of independence, direct cost, for example, hospital costs, and indirect cost, for example, the loss of productivity. This report estimated that in 2010, the total cost of injuries in Canada was $26.8 billion. Of these costs, $15.9 billion were due to direct costs, and $10.9 billion were due to indirect costs. The mechanism of injury associated with the highest costs were falls, $8.7 billion, transport incidents, $4.3 billion, and suicide/self-harm, $3 billion. Now that you have a better understanding of how to classify data, frame a research question, where you can access injury, morbidity, and mortality data, and how to interpret injury reports, let's do a matching exercise to see what you've learned. Below, you will find a few resources if you are interested in learning more about data methods, interpretation, and surveillance. There are two parts to complete the evaluation of this module. The first part is intended to assess if you have shifted your readiness to tackle surveillance. The first question asks you how you felt before you began the module, and how you feel now that you have completed the module. The second question is about behavior change. The second part of the evaluation of this module is a feedback form. This feedback form will help us to improve the quality of this module. Please click on the link in the question panel to complete the survey.